Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Our guest today is Dr. Philip J. Mease. He is the Director of Rheumatology Research at Providence Swedish Health and Clinical Professor at the University of Washington School of Medicine in Seattle, Washington. His clinical practice is based in Seattle with Seattle Rheumatology Associates, a Providence affiliate, and he earned his undergrad and medical degrees at Stanford. He then completed residency in internal medicine and a fellowship in rheumatology at University of Washington. His research interests include psoriatic arthritis, spondylitis, rheumatoid arthritis, osteoarthritis, systemic lupus, fibromyalgia. He is the past president and founding organizer of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, or GRAPPA, and is highly involved in the rheumatological community far and wide. So we are super excited today to welcome you and to talk about psoriatic arthritis and some research updates on the topic.
Thank you very much, Jill.
So we are going to spend the next few minutes talking. I know there's a lot of crossover between psoriatic and spondyloarthritis, and then there's some differences. Can you give us an idea of psoriatic arthritis, what it is, and how it differs from other forms of arthritis?
Psoriatic arthritis is an immunologic inflammatory condition which occurs in about 30% of people with psoriasis. And we know that psoriasis, which is a skin condition in which patients develop these terrible, itchy plaques all over their body that are scaly and unsightly, occurs in about 3% of the US population and to varying degrees in other populations around the world. And in any given psoriasis cohort, you'll find about 30% of the patients having some form of musculoskeletal inflammation that involves joints, so small joints of the fingers, wrists, knees, feet, and so forth, but also potentially the joints, ligaments, and bones of the spine. Some of the other characteristics include inflammation wherever tendons or ligaments insert into bones. So, for example, the Achilles tendon, where it inserts into the heel, or the plantar fascia at the heel, or around the rib cage, or around the knee. And so a person can have multiple sites of inflammation and pain, which leads to physical disability and sometimes deformity. It's a member of the spondyloarthritis family. And when I say that, what I mean is that there are certain genetic associations that are very close between psoriasis, psoriatic arthritis, what is now known as axial spondyloarthritis that we used to call ankylosing spondylitis, and also other conditions that are closely genetically related. For example, there's a condition called inflammatory bowel disease, Crohn's or ulcerative colitis, where the person can have musculoskeletal manifestations of spondyloarthritis or psoriatic arthritis. We know that individuals who have something called uveitis, an inflammation of the eye, it's also closely associated. People who get an infectious stimulus and they get something called reactive arthritis to a certain infection may have predominant spondyloarthritis type features. So this is all one big family. And when you add them all together, it turns out that roughly 2% of the US population, if not more, has one of these subsets of spondyloarthritis,
Wow.
whereas only about 1% or less have rheumatoid arthritis. Yet when you talk to a primary physician or a patient, they've all heard of rheumatoid arthritis, but what the heck is this spondyloarthritis thing you're talking about?
Yeah, it's funny you say that. I mean, we talk all the time about how many people are estimated to have spondyloarthritis, but I've never contextualized it into the percentage of the population. That's
It's a lot of people.
It's a
And,
lot of people.
And the other sad point is that many of these patients are undiscovered.
Right.
They have back pain. Well, back pain occurs in everybody. Go into a primary care physician. Sure, you've got mechanical. They get an X-ray. There's some degenerative changes. Oh, you've got degenerative arthritis of the spine. Not realizing that this patient that feels like the Tin Man from Wizard and Oz is actually a person with spondylitis, and they would do so well with one of our new and improved medications that really can sometimes put these conditions in remission.
Yeah.
So I'm always on the bandwagon of trying to educate not only primary care docs and physiatrists and orthopedists and physical therapists, but also the large swath of the patients out there who have back pain or peripheral joint inflammation or heel pain or psoriasis. Really think about the possibility that your musculoskeletal inflammation is due to an immunologic condition that can be readily treated in many cases.
Yeah, we talk a lot about here and just in the SAA community about if we can get to a point where inflammatory back pain isn't just discussed in the rheumatological community. If we can get people to understand that this is a huge contributor to disability in the United States and beyond, and that it actually is, there's differences, and a lot of specialties don't even look at it differently.
That's absolutely right.
Yeah. So maybe we can start a new I don't know, is that a campaign or a business to get people to learn it? So you talked a little bit about, right? So psoriatic arthritis falls under this umbrella of spondylitis and or spondyloarthritis. And I often, when I meet someone with anything under that umbrella, I always call them my cousin because I think they're very similar. But what are the most common symptoms like of psoriatic compared, maybe in comparison to some of the other my brain just broke.
No, that's fine. So for this audience, probably one of the most important comparisons is going to be with in comparison with individuals with what we used to call ankylosing spondylitis. Notice that I keep using the phrase "used to call."
Right.
It turns out that the phrase ankylosing spondylitis, which was coined back in the late 70s and 80s, really brings forth the image of a young male HLA-B27 positive who already by the time they're in their late 20s or early 30s have evidence of these bridging calcium deposits that unite the vertebra and cause this ankylosis or bamboo spine type of change that is the most severe form of ankylosing spondylitis, along with ankylosis, that is gradual fusion of the sacroiliac joints at the base of the spine. So that's the old concept. Then, as we moved along into the 90s and more recently, with the advent of MRI technology, we began to see that there were a whole bunch of people out there, especially women, who had evidence of inflammation in the spine or sacroiliac joints, but did not have the ankylosing changes, the changes that you can see on X-ray. And all of a sudden, we discovered as many people, if not more, who had this broader condition that then got the name changed to axial, meaning just spine and not inferring ankylosing, and spondyloarthritis. So that's the new term. And we get to the new ICD code in a few years, where we numerically code the different diseases of the patients we're seeing, that the old term ankylosing spondylitis will go away, and we'll just have the newer term, which is now including all these people that show up with inflammation on MRI scan or have a positive HLA-B27 and other characteristic features like uveitis or inflammatory bowel disease. So if you then move over to psoriatic arthritis, what are the key differences? Well, for one, we from the very beginning, we know that it's equigender. It equally involves males and females, unlike the old concept of ankylosing spondylitis, which was predominantly male, and the rheumatoid arthritis, which is predominantly female. The other features are that there's a lot of what we call peripheral disease. So lots of inflammation and pain and stiffness of the finger joints, the wrist joints, the feet and ankles and knees, for example. They can also have spine involvement. For example, on average, about 50% of patients with psoriatic arthritis will have some degree of spine involvement, but it may be very different than the classic person with axial spondyloarthritis. For example, it may start in the cervical spine rather than down in the lower part of the spine. They may not have sacroiliac joint involvement at all. Oftentimes when you ask the patient about pain and stiffness, it has a slightly different flavor, although can be as severe as the people with axial spondyloarthritis. And it can occur later in life, and often gets confused with degenerative arthritis when it starts to occur later in life. And we're starting to learn that there may be differences in treatment response. So some of the treatments that work in the spine condition of psoriatic arthritis may not work as well in axial spondyloarthritis or vice versa. So it's really getting important to really understand the immunobiology of the patients we're treating and having biomarkers and so forth that are going to be able to teach us, instead of just throwing a dart against the dartboard about what therapies to use, really picking the best treatment for the patient that's in front of us.
I don't know if everybody listening realizes there's so much good work that has gone on in this area in the last really 20, 30 years. And while there is way more to do, right? Because we have all these undiagnosed, underdiagnosed, misdiagnosed, and, there's still work to do, but let's acknowledge that we have some good things going on and there's room for improvement. But what are the most recent developments like around psoriatic that we're learning? I know I just came from the unmet needs for spondyloarthritis, and it was fascinating, like just to be a fly on the wall, even not a researcher. But what's happening in psoriatic specifically?
Well, there's several things. So first of all, I should, although this gives away my age, when I first was a fellow in rheumatology back in my training days, this audience might be a little horrified to know that the main treatment that we use for treating rheumatoid arthritis and psoriatic arthritis were weekly injections of gold.
I've heard that.
Isn't that amazing?
Yeah.
So then right around that time when I was a fellow, one of my mentors at the University of Washington was a pioneer in the use of methotrexate, which started in dermatology with the use of low-dose methotrexate for treatment of psoriasis. And then we borrowed it to treat rheumatoid arthritis and psoriatic arthritis. Not so effective, unfortunately, in axial spondyloarthritis. And so that, for a couple of decades, methotrexate ended up being the mainstay of therapy. Then in the very end of the 1990s, I had the opportunity, living in Seattle, to work with a company called Immunex that was developing a drug known as etanercept, the trade name is Enbrel for that medication. And so because I was seeing a lot of patients with psoriatic arthritis, I asked Immunex, could I have some of this drug and do an independent investigator study of patients with psoriatic arthritis? So we enrolled about 60 patients over the course of 4 months, treating half with etanercept and half without. And lo and behold, it was quite effective with reduction of joint swelling, joint pain, improvement of fatigue, really significant improvement of physical function, ability to work. And that was the first trial of a effective biologic therapy for the disease. And it showed that it also worked well in the skin and really diminishing the skin plaques. So that started off a whole sequence of trials with first various anti-TNF medications like adalimumab and infliximab and so forth. And then that went on for about a decade of using those medications primarily. And then we started to see a bevy of other treatments being tested based largely on a better understanding of the immunobiology of how the skin lesions occur and how the joint inflammation occurs. Once we started to piece together that certain molecules like interleukin-17 or certain T lymphocytes or the role of interleukin-23, all of these molecules that were involved in inflammation, we could really see that they were causing inflammation and tissue destruction in these patients. And once you could develop drugs that inhibited the function of these various targets, then we started to see great effects with interleukin-17 inhibitors, interleukin-12-23 inhibitors, interleukin-23 inhibitors, Janus kinase inhibitors, and the list goes on. There's several promising new treatments that are in the pipeline now. So we're in a stage of having just a bounty of effective medicines. And for the first time, unlike the days when we were only using methotrexate, and especially only when we were using gold therapy, we're now able to get people into a state of what we call low disease activity or remission. And one of the roles of the GRAPPA group over the years has been not only to unite rheumatologists and dermatologists around the world in an interest in figuring out about the disease and how best to treat it, but also how to measure it. So we can now measure in the clinic the severity of disease, and we can treat to a target of keeping the patient in low disease activity or remission, which we know is critical for preventing downwind destructive changes of the joints, and also hopefully ameliorating some of the other comorbidity problems that patients have, like cardiovascular disease, that often accompanies states of inflammation.
That's fascinating. And when I think of this like targeted, right, and you're talking about the comorbidities and how we're changing the way we treat things, I think of this, it's like this multidimensional, right? Like each person is this multidimensional human. And I just think of all the combinations you guys must have to go through in your heads. But I will say, at least when you were a resident, it was mostly that women didn't have these diseases, right?
Didn't have axial spondyloarthritis, but we knew that women had psoriatic arthritis.
Okay. Right? Gotcha. I met a doctor at the beginning of COVID who looked at me sideways when I said I had spondyloarthritis. And she said, well, what do you have? And I said, ankylosing spondylitis. And she said, that's not possible. Women don't get it. We'll just leave that one there. Okay. So lots of good, promising things happening. How about to back up for a second? before we end this, I am gonna go back and ask you why you became a rheumatologist. We're gonna end on that. But I want to go up one level for the patient. And what are environmental or genetic factors that could contribute to the development or exacerbate the condition?
So one that I'll point to that is a common issue is obesity. We know that individuals with psoriasis are genetically predisposed, unfortunately, to becoming obese and having the cardiovascular triad of hypertension, hyperlipidemia, or high cholesterol, along with obesity. And these all contribute to the cardiovascular comorbidities that lead to potentially early heart attack and stroke unless the inflammation is adequately controlled. But it turns out that, again, coming back to obesity, that even if a patient works as hard as they can, diet-wise, exercise-wise, to control their weight, it's tough. And this is partly, again, driven genetically. And we know that if a person is obese, they have a slightly higher risk of developing psoriasis and psoriatic arthritis. And we also know that if you adequately reduce weight with various kinds of dietary approaches and exercise approaches, that the disease itself will diminish in intensity. And when you then use a medicine, was a famous study where the question was asked if a patient, one group didn't have a dietary control, this was all done in Naples, Italy, where putting people on a very low-calorie diet, which is a crime in Italy, I have to admit, that group, when given a TNF inhibitor, was much more likely to be able to get to the target of minimal disease activity, which is a target. It's a complex set of characteristics that we measure in the clinic and then use as a target for therapy. So just knowing that by reducing weight can ameliorate disease is, I think, very important, because oftentimes I'm asked, Doc, what can I do? I know you're giving me this medicine and I really appreciate its effect, but what can I do? And one is to reduce weight and the other is to exercise within reason. You know, obviously, if you've got a really bad knee, don't go doing marathons, but doing exercise regularly is very helpful for your disease state. There are also a number of naturopathic remedies that I think are of interest. Unfortunately, in the naturopathic world, they don't really subject their dietary or nutraceutical treatments to good placebo-controlled trials, but I hear plenty of anecdotal evidence of various naturopathic approaches being potentially helpful. And then lastly, I'm going to just say mental health, use the phrase mental health. It turns out that depression is, and to a lesser extent anxiety, are major comorbidities for people with psoriasis and psoriatic arthritis. Just imagine the double whammy of having the embarrassing skin disease and painful function-limiting musculoskeletal disease. Depression sets in. Up to a third of patients can experience this. And we know that when you're depressed, there can be more fibromyalgia, more of this central sensitization phenomenon. There can be, and just having an autoimmune disease can give you more fibromyalgia, the inflammation of it. And whenever those comorbidities are present, depression, anxiety, fibromyalgia, the patient tends to have worse pain, more fatigue, more sleep disturbance, and less ability to do their work and function with their family. And so those are things that I would call, in a way, they're environmental in that they can be modifiable and move to a state of better emotional health, to be with your family, to be with your friends. That's really important for disease management.
Yeah, we've done a number of episodes on mental health, pain management. We just did another one with Afton Hassett from University of Michigan.
Yes,
She's
I know
fast.
Afton. Yeah,
Have you seen her new book? It's amazing.
I know of the book. Yes.
It should be. I did the protocol, so it was great, and I think it's mental health hit me sort of like square in the head with this disease, and I think it does a lot of people because if I'm not mistaken, right, we also like what goes on in our brain is dictating some of the things we feel in our body, and some of it is neurotransmitter related, which if we're predisposed to maybe, and I don't know that this is a truth, but I do remember reading somewhere that sometimes people with ankylosing spondylitis at the time produce less serotonin or dopamine. I think there are things that we have to remove the stigma around the mental health piece because it's so important.
Yeah.
And at the end of the day, if we don't get the dishes done, but we laugh, that's probably good enough.
There you go. I like that.
You can tell that my mantra. But yeah, I think the mental health piece is huge for people. As is, it can be a struggle. All of this goes back to that multidimensionality, right? Of there's so many things that we're trying to kind of firefight within in an immunological disease. So I love hearing that. I think, well, I don't love hearing that mental health is a struggle for many patients, but do you think in terms of what's coming next in psoriatic arthritis, anything you want to give us a sneak peek on, or you think is a promising new development in research?
Well, I go back to some of the pharmaceutical approaches that we were discussing earlier. And yes, there are a number of new developments. For example, just last week, we had a major new approval by the FDA of a medicine that is an interleukin 17A and interleukin 17F inhibitor. So a dual mechanism, unlike the currently used IL-17A inhibitors, A alone. So that's was approved for psoriasis, and we are anticipating next year its approval in both psoriatic arthritis and axial spondyloarthritis, both the radiographic form of axial spondyloarthritis, i.e. ankylosing spondylitis, as well as the so-called non-radiographic axial SPA, the ones that are MRI positive or B27 positive. So major new example of an approval. We have some really fascinating drugs in the pipeline along that same line of interleukin 17A or A and F inhibition, and they're called nanobodies. So instead of being the big, huge proteins that we're currently injecting, like the ones that everybody that might be on biologic therapy that's listening are using, these are tiny little molecular fragments. So like, for example, when you're injecting adalimumab or Humira, or you're injecting Cosentyx or Taltz, they're about 150 kilodaltons in size. These new nanobodies can be as small as 14 or 15 kilodaltons. And that's interesting because then it may allow them to get into being small in size and binding to albumin as well as IL-17. They may get into some of these difficult to treat places, like some of the aspects of the spine or the right where the Achilles tendon is inserting into bone. And they're being actually data from their data is being presented in a little over a week at the ACR meeting, and some really exciting and very good quality results with each of the mechanisms I've just described. Bimekizumab, the recently approved drug for psoriasis, and then these new antibodies, which have more and more unpronounceable names, like izokibep and sonelokimab. In the morning, I get up like Demosthenes and stand in front of the mirror and just sort of say these over and over again so they can roll off my tongue. And then there's a whole other group of drugs coming along that are called TYK2 inhibitors. One that's been recently approved for psoriasis called deucravacitinib, and it will be again approved sometime next year for, we think, or the year after, for psoriatic arthritis. And then there are a whole bevy of TYK2 inhibitors that are in the pipeline. We've got MK2 inhibitors, and some of these are medicines that are taken in a pill form, so they don't all have to be injected, which is going to be a convenience to some people. We've recently had an intravenous form of the interleukin-17 drug Cosentyx or secukinumab approved by the FDA, which now will allow patients of Medicare age to get that drug at lower cost or no cost. So what can I say? This is just a bevy of new drugs coming along. Either fortunately for psoriatic arthritis, unfortunately for axial spondyloarthritis, not all of these drugs are proving to be efficacious in both conditions. We seem to have a few more that are good for psoriatic arthritis. And fortunately, most of these new medicines are safer than some of the older biologics, and number one, and number two, they generally are able to cover all of the areas we want them to cover: skin, joints, entheses, spine. So that's good and important for patients.
I love it. If someone could get rid of the Achilles tendon pain, that would be like amazing. Okay, so two questions left to go. One is, I'm not going to let you off the hook on your journey, but the first is, how can providers work with patients to create personalized treatment plans, and what can patients do to participate in that for a better outcome?
So several ways of responding to that. One is that we still, I think, have a ways to go to get to the place that many of the cancer doctors are, which is being able to really carefully immunophenotype, understand the immunologic signature of the patient in front of them, to then pick which drug or combination of drugs is going to best fit that immunophenotype. We're not quite there yet with psoriatic arthritis and axial spondyloarthritis, but we're getting there. Multiple laboratories are working on identifying these molecular biomarkers to better pinpoint which drugs are going to be best and safest for the person in front of us. So that's true personalized medicine, and we're going in that direction.
And did that all sort of, like in rheumatology and in cancer patients, did that all sort of, was it born out of biologics becoming developed? And I know, like in the cancer side, like Keytruda changed cancer, right? Is it sort of one driving the other?
So that's a great question, because what you're getting at is that sometimes we try a therapy, and by seeing the response, we then look back and say, oh, this must be an important mechanism, immunologic or biologic mechanism. And so it's a two-way street. We're learning things in the laboratory with tissues and rats and so forth, but we're also learning backwards from seeing the responses to treatment with these very targeted therapies. So yes is the answer, and we will get there. But if we get into a more prosaic place where we're asking the question, how can we better take care of the individual patient in front of us? There are a couple of things I want to mention. One is this whole importance of figuring out all of the domains that are active in the patient: spine, entheses, joints, skin, nails. And I liken it to an orchestra where at any given moment, the orchestra all of the sections may be playing fortissimo. And so you want to hit it with a big gun that's going to suppress all of it, bring everybody into a quieter place, pianissimo, hopefully. But there might be times when, for example, the violins and the cellos, but the piccolo has a little solo, and that's that person's right Achilles tendon. And so it's identifying that particular piece, even though generally they're doing well, that we need to get better at and be able to attend even to that single piccolo player doing his or her piece. And so it takes a little longer in the clinic visit, but patients really appreciate it when they sense that you're really comprehensively asking them about all these different potential tissue domains that are inflamed, but also that they're being cared for holistically. And I think that builds trust. And since these are long-term relationships we have with people, this is important for relationship building. The other key piece there for this individual patient is think about the village of people that are involved in helping take care of that patient. Let's say they have inflammatory bowel disease, then you have to have the gastroenterologist in your cell phone contacts list, because it might be that the gastroenterologist wants to use a specific drug for the patient's small or large intestine inflammation, whereas we may want to use and benefit more from another drug that's better for their musculoskeletal dimension. And so working together is very important. And an example of that is a current trial in which we're putting together a drug that's an interleukin-23 inhibitor along with the TNF inhibitor, which are commonly used by gastroenterologists and rheumatologists to control either ulcerative colitis on the one hand or psoriatic arthritis on the other. A fascinating group of trials coming out of Janssen, known as the Vega trial and the Affinity trials. So putting together combinations. We work with the ophthalmologist for the uveitis. We work with the psychologist because of depression. And within our clinic, I work with 3 advanced practice practitioners, 2 nurse practitioners and a physician's assistant. So we're a quartet, which really allows us to know the patient well. When I'm doing things like having this interview, they're in the clinic seeing the patients, and so it's more around the clock care, and the patient gets to, let's say it's a young 38-year-old woman, she gets to interact with a female nurse practitioner that's her age and talk about some of the things that they may talk about. And then this old guy comes in the room and I talk about clinical trials and data and so on and so forth. And so they feel like they're getting the best of both worlds, something more intimate and something more, if you will, cerebral. And so what I'm getting at is how much it takes a village to really effectively care for some of these complicated patients.
I love that description. I was I wouldn't underestimate your ability to connect with people either. If you're calling yourself the old guy with the data. Okay, so I'm going to land on this one and then we're going to wrap it up. But I could talk about this all day with you. What made you choose rheumatology?
That's a great question. So I think what I'll do is I'll dial back to when I was in medical school. I was at Stanford at the time, and for whatever reason, I was emotionally and psychologically and intellectually really drawn initially to cancer medicine. And I was, of course, it just sort of engages your whole being, your intellectual being, but also your heart when you're taking care of a patient who's dying in front of you. And I had a very inspirational mentor, a physician at Stanford that was encouraging me in that arena. But during my sub-internship there, I had the experience of admitting a young male with testicular cancer toward the beginning of my rotation, and toward the end of my rotation, he died. And I remember just being torn apart emotionally by this. And so when I started getting more exposed to rheumatologists at the University of Washington, there were some very inspirational faculty, one named Bruce Gilliland, who was just a wonderful human, as well as being very smart, and one of the editors of our major textbook of medicine, contributing the rheumatology section of that textbook. And then I also had some immunology scientists that I worked with, and I worked with in helping, I won't get into the details, but a very complex patient. I was involved in a cure of this particular patient's immunologic condition. And I began to realize that the rheumatology involved the same interesting issues around immunologic science, manipulating the patient's immunologic fabric, and trying to improve their disease, but patients lived, and they lived long term. And I follow patients in my clinic that I've seen for 30 years.
Wow.
Just imagine growing up with someone from when I was younger, in my 30s, and they were in their 30s, and now we're both in our current ages. It's like growing up with a family member over time. And so only a family member you get along with, as opposed to someone you don't get along with. And so it's even, I think, even better in some ways than a family practice situation where there's all this transition in and out, and we've these long-term relationships and friendships with patients really makes it for me. It's what makes it fun to get up in the morning and go to work and see all day long, see patients that I've known over time, as well as people that are brand new, struggling with these emotional as well as physical issues, and helping them move through this trying time, and getting to, now that we have all these remarkable therapies that can get people into remission or low disease activity, we're seeing them get there, and how appreciative they are. What's better than that?
Yeah, I mean, I fully intend on celebrating my 100th birthday with my rheumatologist. And she's somebody who I often say she saved my life. And it's great. That is wonderful. Thank you so much for that, and for your lifetime of work that you've done in a third of a lifetime so far for this community. It is, your contribution is a little bit beyond comprehension when I think about GRAPPA and all those things. So thank you for all the work you do, and for joining us today.
Thank you so much, Jill. It was a pleasure.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie.
Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.